And I would like to introduce Dr. Alice Hadchouel from Paris, from the Hôpital Necker. She's very much interested in an expert in rare diseases. So now we come from the common things like asthma, bronchiolitis to the rare disorders. And you will have actually now 2 presentations in a row, one on PPD and the other one on ILD. And there will be 2 more online modules that all the participants can look at, which are on systemic disorders with lung involvement and also surfactant dysfunction and alveolar proteinosis. So welcome, Alice. I'm happy that you will give us the 2 talks, and please go ahead. Thank you.
Okay. Okay, so, oops, sorry. I made a mistake with the full screen with my slides. Okay, that's good. So first, we will talk about bronchopulmonary dysplasia, which will be called BPD for the rest of the talk. Okay. So I have no conflict of interest for this talk. So BPD is the most chronic respiratory disease in premature infants. And with progress in medical care and better prevention of risk factors in the last decades, the incidence of this disease decreased very much, but is still important in the most premature babies, with about a third of children that are born before 28 weeks of post-menstrual age with the disease of BPD at 36 weeks. It is a source of significant respiratory, but also of neurodevelopmental morbidity at mid and long term, and it makes major demands on health services with high costs. So BPD is defined by a prolonged respiratory failure, and we will interest especially in moderate and severe BPD. And so to diagnose BPD, there are 2 steps in the evaluation, in the assessment. The first one at 28 days of life, and the second one at 36 weeks. And when a child still required oxygen or ventilatory support at 36 weeks, then he will be diagnosed with moderate or severe BPD, depending on the level of support. This algorithm can be completed by a standardized and physiological oxygen reduction test that was described by Roche in 2004 and which is used in many neonatal intensive care units. To understand how the development of BPD can occur, one has to know the different stages of lung development, which are 5. And on this slide, you can see that the saccular and alveolar stage of lung development occur nearly before birth, and for the alveolar stage, it takes place mainly after birth. And that will explain that preterm babies will be born at the end of the saccular stage or at the early beginning of the alveolar stage. Bronchopulmonary dysplasia correspond to a disruption of alveolarisation because the alveolar stage of normal lung development corresponds to the subdivision of primitive alveoli to lead to definitive alveoli and to an increase of the gas exchange surface area associating to a slimming of the alveolar walls. And that will allow to obtain the definitive alveolar capillary barrier. This stage required important phenomena of extracellular matrix remodeling and maturation of the microvasculature of the alveolar walls. And so in BPD, you will have alveolar hypoplasia with fewer and larger alveoli, as you can see on this pathological image of a child with BPD, with a scarcity of the capillary bed and dystrophic vessels. What are the mechanisms of BPD? They are multiple and numerous, and the premature birth will expose the baby to many environmental injuries that will occur on an immature lung, And those two phenomena will interact with factors that control the normal distal lung growth, and they will occur on an immature lung, especially in terms of mechanisms of repair. And that will lead to chronic lung disease. This chronic lung disease is related to disruption of the key stages of secondary septation, as I showed you just before, that are elastogenesis, extracellular matrix remodeling, and angiogenesis, and all those phenomena will be disruptive in BPD. The BPD is not only an environmental disease, because now it is well known that some genetic factors are also involved in the development of the disease, but I will not have the time today to talk about it. And the chronic lung disease will be characterized mainly by hypoalveolarisation in the neonatal period, because BPD is defined by a prolonged respiratory insufficiency. But in the most premature baby, this hypoalveolarisation may be associated to a real pulmonary vascular disease with a risk of pulmonary hypertension. And in the later, what will be the main feature of children and adults that have bronchopulmonary dysplasia will be a predisposition to an obstructive pulmonary disease. The main risk factors for BPD that have been determined by large cohort studies are lower gestational age, small for gestational age, male sex, a core body temperature of less than 35 degrees on admission to the NICU, invasive ventilation begin within 24 hours of birth, clinical sepsis, feeding with formula milk, so those children must be fed with breast milk, it's better. Patient treated with surfactant, or for patent ductus arteriosus, especially if they need a surgical treatment for patent ductus arteriosus. Regarding those two factors, the surfactant and treatment for patent ductus arteriosus are not real risk factors for BPD, but they reflect the severity of the baby's condition. So they are associated to an evolution toward BPD. And there is also the genetic susceptibility. So BPD is mainly a disorder of prematurity, and here you see the results of the EPIPAGE-2 cohort study, which is a French birth cohort that includes babies that were born preterm, but also controlled babies that were born at term in 2011. And here you see that the more premature you are, so with the gestational age being earlier, the more you have the risk to develop a severe BPD. The development of BPD is also related to birth weight, and especially to the existence of intrauterine growth retardation in children that are small for gestational age. And here you see that when you are born with when you are small for gestational age at birth, the odds ratio for the development of BPD increase when the centile of birth weight decrease. Regarding pathological mechanisms, I will focus on two main pathways, inflammation and oxidative stress. Inflammation will occur very early in those babies and will interact with factors that control normal distal lung development. It has been shown first in animal models of bronchopulmonary dysplasia, but now we have studies that were performed on human babies like this one. Those babies underwent daily cytokinic dosage from birth to day 42. And you can see that increased cytokines like IL-6, IL-8, and also GCSF are increased right from birth. So it's very early as in children that will evolve toward BPD as compared to children that will not develop BPD. You can also see that the increase in cytokine dosage precede the need for oxygen that will separate babies that will be diagnosed with BPD as compared to babies that will not be diagnosed with BPD at 36 weeks. And this inflammation also occurs before the occurrence of a sepsis if it's occurred. And so the inflammation is like constitutive in those babies. And there is more inflammation in small for gestational age baby and boys. And those results were independent from gestational age, birth weight, gender, the occurrence of a prenatal infection, or the use of steroids or non-steroids anti-inflammatory drugs in the neonatal period. So those results arc for the interest for an early anti-inflammatory intervention in those babies, with, why not, a prophylactic preventive treatment, as it has been done in the Premilox study that treated preterm babies with hydrocortisone during the 10 first days of life. In those babies, the role of oxygen and oxidative stress is also very important for the development of BPD. And it will interact with the mechanisms of repair that are immature in those babies. Indeed, in babies that are born at term, there is an increase in antioxidant enzymatic activity just before birth. And this is made to face the transition from the hypoxic fetal environment to the normoxic extrauterine environment. In case of preterm birth, those phenomena will not occur because the birth is occurred too early. And you will have an imbalance between the immaturity of the antioxidant machinery and the hyperoxic aggression that will be important in those babies, leading to production of oxidative oxygen reactive species. Here is the summary of the possible consequences of the increase in oxidative stress in preterm babies. The oxidative stress will interfere with normal lung development players like vascular endothelial growth factor, the stress of the endoplasmic reticulum, and also the alveolar epithelial cells. That will lead finally to airway and blood vessel remodeling. The oxidative stress also linked to an increase in reactive species from oxygen production, which increase the apoptosis. It will also lead to some inflammation, and all those things, all those phenomena will interfere with and interact in an immature lung, which is immature, especially in terms of antioxidative defenses. So, as I told you, inflammation plays an important role in the development of BPD, and it may be a phenomenon that is intrinsic to those babies and not secondary to sepsis or ventilatory procedure or oxygen. Many years ago, systemic steroids has been used, initially largely for long periods and with high dose, but even if those steroids have a proven strong effect to decrease the incidence of BPD, they also have neurocognitive deleterious effects later in infants with a high rate of cerebral palsy. So now systemic steroids are restricted to exceptional clinical circumstances at minimal dosage and for a limited time. And here are the more recent guidelines for their use. The NICE guideline in 2019 say that dexamethasone should be considered to reduce the risk of BPD for preterm babies who are 8 days or older and still need mechanical ventilation. And here is the recommendation from the 2019 updated European Consensus Guideline. A short tapering course of low dose or very low dose dexamethasone should be considered to facilitate extubation in babies who remain on mechanical ventilation after 1 or 2 weeks. what will be next? I think that will be the impact of the Premilog study, which used hydrocortisone for all babies that were born very preterm. And I know that, for example, in France, some NICU teams use this protocol for the babies that are the more at risk of developing BPD. They treat them from birth with hydrocortisone. What is the place of inhaled steroids? The first Cochrane analysis shows no effect, but then the neurosis study has been published and show a proven effect of an early administration of inhaled steroids on bronchopulmonary dysplasia that was significant, but also an increased mortality, but that was not significant. Another study show the positive effect of the intra-administration of both surfactants and budesonide for acute respiratory distress syndrome with a decreased incidence of BPD or deaths. And so, owing to those studies, in the 2019 updated European consensus guidelines, inhaled budesonide can be considered for infants at very high risk of BPD and sometimes allow to reach a step, for example, weaning of oxygen or weaning of mechanical or non-invasive ventilation. Other treatments that can be used in the neonatal period to prevent the evolution towards BPD, there are few. Inhaled nitric oxide should not be used because several international studies and trials show that there was no benefit of the treatment on BPD. Caffeine that is routinely used to prevent apnea in those newborns had a small positive effect on BPD, as vitamin A, but its routine use is difficult. And there is now a hope for mesenchymal stem cells or endothelial stem cells used for the prevention of BPD. And there has been many studies on animal model that prove to be to have a positive effect on the development and of the prevention of BPD. And in humans, there has been, to my knowledge, only one phase 1 clinical trial on 9 infants that show a decreased inflammation. And when you go on clinical trials, there are several ongoing on planned clinical trials, but without any results, and especially in Asian countries. So what is the care of those babies after the neonatal period and after they are discharged home? Some will be discharged home with oxygen supplementation that have to be monitored closely. Those children may be evicted from community daycare at least for the first year of life because viruses, infections will be the main risk factor for them to get a severe infection and a severe wheezing respiratory distress. This protection against viruses associates also anti-influenza immunization and palivizumab when indicated. You should avoid tobacco smoke exposure for those children, as in other respiratory disease. Nutritional support and nutritional and weight monitoring and growth chart monitoring is very important because those children with BPD have a higher energy expenditure. And inhaled steroid treatment must be prescribed only if with these symptoms. And so those children should be closely monitored the months following their discharge, especially for growth, feeding, respiratory and cardiac signs. And the pediatric pulmonologist's advice is required when there is, for example, an impossible weaning of oxygen after several months or permanent respiratory symptoms. The cardiopulmonary assessment before discharge is very important in children with moderate or severe BPD and should associate a nocturnal oximetry and also a cardiac ultrasound. If the pulmonary pressures are increased, the physician should optimize oxygenation with higher SpO2 targets. And if the pulmonary pressure remain increased, then you should discuss with the cardiologist the indication of a right heart catheterization. Here are the French criteria to introduce supplemental oxygen. So in children with BPD, we are most of the time in children that are less than 2 years old. And so oxygen should be introduced or maintained when the mean SpO2 is less than 93%, or where there is more than 5% of the sleep time with the SpO2 lower than 90% and or increased pulmonary pressures. Once you have introduced the oxygen, your targets are defined and depend on the existence of pulmonary hypertension or not. If there is elevated pulmonary pressure, then you should have a high SpO2 target that should be more than 94%. And if there is no pulmonary hypertension, then the target should be more than 92%. The American guidelines for home oxygen therapy in infants with BPD are quite close from the French one. In children aged 1 year or younger, the oxygen should be prescribed if they spend more than 5% of the recorded time with less than 90% of SpO2 or if there is 3 independent measurements of SpO2 lower than 90%. And also the targets will depend on the existence or an elevated pulmonary pressure or not. To end, some slides about the mid and long-term consequences of preterm birth and BPD on respiratory status. So what we know is that those children are at higher risk to display respiratory symptoms and to be hospitalized for respiratory cause in the 2 first years of life, as you can see on this chart, and it's confirmed by all other studies. There is a higher risk of pulmonary medication or rehospitalization for pulmonary cause as the degree of BPD increase. Later in life, for school-age children, there is also more asthma in those children that were born premature, and it is associated with gestational age, and it is worse in children with BPD, as you can see on these slides. In blue, the control; in purple, the infants the children that were born preterm without BPD, and in green, the children that were born preterm with BPD. And you see that you have higher asthma, exercise-induced with asthma medication, and nocturnal cough. Later in life, in teenagers, you also have an impact on symptoms and on FEV1, as you can see here in teenagers from the EpiPage 1 cohort. And in this study, we showed that BPD and preschool wheeze were independently associated to FEV1 at adolescence, that suggest and strengthen the importance to follow those children. In adulthood, there is also clinical consequences of premature birth and BPD with more respiratory wheezing symptoms and cough. The previous slide was included children that were born both in pre and post-surfactant era. In this study, there is only children from the post-surfactant era, and the clinical results are quite strange because, as you can see here, there was no difference in asthma and asthma treatments between BPD and controlled children, but I think there was a bias in selection of controls because control were volunteers. So I think that the ones that were the more prone to participate were the ones that had asthma symptoms. Anyway, when you look at lung function test in those young adults, you see that there is a decrease in FEV1 in patients with BPD, but not in controls. So as I told you, there is an impact on FEV1 in children that were born preterm with or without BPD, with a worsened role of BPD. If you look at time course evaluation, the lung function test remain lower in subjects that were born preterm in childhood, but also in teenagehood and in adults. There is no catch-up of lung respiratory function in those individuals when you compare preterm versus to controlled and when you compare BPD and non-BPD subjects. And physical activity is also impacted and altered because children that were born preterm with BPD has a lower perception of their performance during exercise and a higher score or shortness of breath with activity when they perform sports. And finally, what you can see also in those children and also in adults that were born preterm with BPD is persistent anomalies on chest CT scan. Here on your right in infants, you see that you have pseudocystic lesions that are related to air trapping phenomenon with retraction sign and subpleural triangles. And you also see those lesions in adults with retraction signs and air trapping lesions. Those lesions are persistent, but they are not related to the clinical assessment when the exam is performed, but it is related to the neonatal history and to the lung function test when the exam is performed. So to conclude, preterm birth interfere with normal lung development and growth because of bronchopulmonary dysplasia, but also because of persistent lung function anomalies. BPD is secondary to environmental, but also genetic interaction in an immature lung. There is no curative treatment to date, and the goal of the neonatologist is to minimize aggressions and propose anti-inflammatory treatment only when it's really required. Mid and long-term respiratory follow-up is mandatory, and preterm birth and especially BPD could be a risk factor for COPD development in adults. So a quick MCQ. So MCQ 1, bronchopulmonary dysplasia is characterized by important airway lesion, hypoalveolarisation with abnormal microvascularization, oxygen dependency after discharge home, persistent surfactant deficiency. Okay, the answer is correct. It was an easy one. So second question. So, second question, bronchopulmonary dysplasia is the result of complex interactions between environmental and genetic factors. The sole consequence of high oxygen exposure and mechanical ventilation is prevented by antenatal steroids, is treated by postnatal systemic steroids. Good. It's a good answer for most of you. Okay, and I think there is a last one. Children born preterm with bronchopulmonary dysplasia are at higher risk of neurocognitive impairment, asthma symptoms, impaired lung function. All the above answers are correct. Good job. Okay, so I don't know, Ernst, if you want me to go right to the next talk or if we take some time for questions now.
We can do it either way. What would you prefer? There are a couple of questions already on PPD, so maybe
yeah, to answer right now.
Yeah, okay.
Okay.
So I tried to group them, and there are have been at least 3 or 4 questions relating to the role of diuretics. So your recommendation for diuretics in patients with or without pulmonary hypertension, and if there is a role still to go on with diuretics once pulmonary hypertension has ceased.
Okay, so there may be a role, but most of the time in those babies, pulmonary hypertension is really related to hypoxemia. So if you treat hypoxemia and if you optimize the oxygenation of those babies, usually the pulmonary pressures decrease. What we see now with more and more very, very preterm babies being reanimated, there is probably a real vascular disease, but the diuretics on this setting will not help, and you have to perform a right heart catheterization to see if there is a real vascular disease and to treat it like other pulmonary arterial hypertension with other specific drugs. But diuretics have a place for children with BPD that tend to be easily overloaded with fluids. And sometimes when you need that those children put on weight, and you have to increase the volumes of their bottles feeding, but they put on weight too much with fluid overload, and so diuretic have to be prescribed for this indication, and then you stop them when after a few months, and you can stop it even if the child is still on oxygen.
Okay. Okay, thank you. Then there is quite a few things on steroids, inhaled and systemic steroids. I start off with systemic steroids because there was one question first. Do you think, what's your opinion on the systemic steroids in a later phase in infants with very severe disease? So for instance, the child is already 3-4 months of age and is still on a high flow nasal cannula with, say, an FiO2 of 0.4 or so.
There are not many studies. We perform one, a retrospective one in Necker. I can tell you about our experience. For children that are at term, so that are 37 weeks or older of gestational age, and that are 3 or 4 months old and that are still dependent on the high need for oxygen or non-invasive ventilation. There is, I think, a place for steroids, but there is no predictive factor that will tell you which child will respond or not. So you can try. What we do sometimes, we try to an oral course with higher dose that are given when the baby is in the neonatal period. And sometimes it's sufficient to, for example, wean from non-invasive ventilation of wean from oxygen. If you have a response, but it's only partial, then you can discuss with specialists IV, high dose pulse of steroids in the most severe babies.
Okay, thank you. And then quite a few questions also on inhaled steroids. So you mentioned inhaled budesonide, and there were some questions on when do you start it, in what dosage, what frequency, for how long do you go with that, and do you do it independent in all prematures of weight, independent of weight or gestational age?
So yes, I do not know precisely the dosage because the neonatologist prescribe it and I don't prescribe it every day. But it's usually budesonide. You can go from 0.5 milligram or 1 milligram for short courses of a few days in the neonatal period, and it will help also sometimes to wean the children from oxygen or from their ventilatory support. And some NICU use that before using oral steroids because it's less invasive than systemic steroids. So you can first start with inhaled steroids for infants that are at high risk of BPD and that are severe in the neonatal periods. And then if it does not work, you can try oral steroids. But on the other side, when children are weaned of oxygen and are discharged home, there is no indication for systematic inhaled steroids. It's only if they've got wheezing or asthma symptoms.
Okay, thank you very much, Alice. I think we have to move on. There will be a few more questions which you maybe can answer in the chat. Then there are more on sildenafil, pneumococcal vaccination, and also CT. But these were single questions, so I didn't group them.
Okay.
Thank you very much.
Thank you.
With ILD.
Okay. So let's move to interstitial lung disease in children. I have no conflict of interest. So ILD in children are a very rare respiratory disease, And in those studies from UK, Germany, Australia, and New Zealand, you can see that it concerns only a few cases per million children in those countries. There are some specificities regarding ILD in children as compared to adults regarding the presentation, the investigation that need to be performed, and the causes. Of note, there is almost 10% of familial case, and what is also important to note is that in many cases, children will remain without any specific etiological diagnosis. ILD in children were classified in 2007 with an update in 2013. And diseases are separated in two groups, diseases that are more prevalent in infants and diseases that are more prevalent in older children. In infants, you have diffuse developmental disorder that will give chest CT scan imaging that looks like interstitial lung disease. And those include especially alveolar capillary dysplasia with misalignment of pulmonary veins that are most of the time related to FOXF1 mutations. And on the CT scan, you can see that you have images, elementary lesions of interstitial lung disease, especially with ground glass opacity that can be very diffuse and also some retraction. The other two groups are, main two groups are specific conditions of undefined etiology that are now called persistent tachypnea of infancy, and that include neuroendocrine cell hyperplasia of infancy and pulmonary interstitial glycogenosis. And the third important group in infants are surfactant dysfunction disorders, including ILD, but also alveolar proteinosis, and it is a topic of an online module. In older children, you have disorders related to systemic disease process, which is also the topic of an online module. Disorders of the normal host, like environmental ILD, hypersensitivity pneumonitis, or toxic or medical drugs induced ILD. You have disorders of the immunocompromised host, for especially opportunistic infections. And you have also some disorders masquerading as ILD, like vascular disease, lymphatic disease, and also intraalveolar hemorrhage that is classified as an ILD. Oops, sorry. So there is one common key determinant of the pathogenesis in interstitial lung disease that is common to the numerous causes. It is the injury of the alveolar epithelium that will lead to apoptosis, altered epithelial mesenchymal interaction, disturbed epithelial homeostasis, and deregulated inflammatory response, which ultimately will lead to lung remodeling and eventually fibrosis. The clinical presentation is not specific. Symptoms are most of the time dyspnea, tachypnea, or exercise dyspnea. Exercise dyspnea is not very easy it's not always very easy to assess in children, especially in younger children. And you have to look for a decrease in usual activities, bottle feeding difficulties. Children may also have dry cough and display failure to thrive or growth retardation. On your examination, you will look for digital clubbing, which will be the sign of hypoxemia, and find crackles on your auscultation. The disease might be discovered during a connective disorder workup or a chest X-ray, which has been performed for another indication. The signs can be grouped in what is called the child syndrome. And to define the child syndrome, you must have 3 of those 4 criteria, which are respiratory symptoms, respiratory signs, hypoxemia, and appropriate diffuse abnormalities on lung imaging. Here are the European guidelines to the assessment of interstitial lung disease in children. So first, you have to collect the medical history and perform a physical examination and a chest X-ray, but the chest X-ray is not sufficient and you will rapidly perform a chest CT scan. Sometimes the chest CT scan will give you a positive diagnosis or strong arguments for a positive diagnosis. For example, in neuroendocrine hyperplasia, cells hyperplasia in infancy. Or it will sometimes evoke some specific features like alveolar proteinosis or surfactant dysfunction disease, and you may proceed directly to the step of molecular genetic analysis in those settings. Most of the time, the chest CT scan will confirm the ILD, but will not give you the cause. So you have to proceed to the next steps, which are some blood tests that include mainly an immunity workup to assess systemic inflammation, a metabolic workup, liver and renal blood tests to look for an extra respiratory involvement. And those blood tests should be associated with cardiac ultrasound, lung function test if the child is old enough, and to search for other extra respiratory involvement. The step after is to perform a bronchoalveolar lavage during a bronchoscopy. And if there is no diagnostic after all those steps, the lung biopsy should be discussed. But if the child is well and stable, progress to the more invasive investigation is not always necessary and should be done only if the child is very severe and if the treatment will be changed as a result. So we'll pass on the American guidelines to keep some time. So when there is a compatible presentation, the medical history should look for ethnic origin, familial history of respiratory symptoms, if the parents are related, swallowing problems to exclude a differential diagnosis of aspiration pneumonia, severe viral infection to exclude the differential diagnosis of obliterant bronchiolitis, extra respiratory symptoms, the existence of an hemoptysis that will suggest an atrial hemorrhage, the environmental exposure, and the toxic exposure. Regarding the chest CT scan, when you analyze it and when you look for an interstitial lung disease, you have to search first for the elementary lesions that will lead to a specific pattern or not. Those elementary lesions include ground glass opacity, interlobular septal thickening, intralobular lines, crazy paving pattern, honeycombing, reticular and reticulonodular pattern, cystic lesion, traction bronchiectasis that are secondary to fibrosis, and architectural distortion that is also secondary to fibrosis. Even if the chest CT scan is a good way to confirm the diagnosis of ILD, it's not a very good exam to make the etiological diagnostic of the disease. As illustrated by this study, where almost 60 patients with a confirmed diagnosis of ILD or of its cause were retrospectively analyzed for their chest CT scan by 2 independent radiologists. And the radiologists make the correct diagnosis with their first choice in only 40% of cases. And there is an agreement between the 2 radiologists in only half of the cases. If the child is old enough, it's important to perform lung function tests in the initial assessment of an interstitial lung disease because it will help you to assess the severity of the disease. You will look for a restrictive ventilatory defect with reduced lung compliance and reduced lung volume, and also a reduced diffusion capacity. If possible, it's important to complete basal lung function test by a 6-minute walking test or a complete exercise test if possible. There is one particularity in neuroendocrine cell hyperplasia and infancy. Lung function tests will most of the time display an obstructive defect with hyperinflation, which is quite typical of this disease if the chest CT scan images are also typical. The bronchoalveolar lavage, which is the next step after the chest CT scan and some blood tests, will give you many information, and sometimes will allow you to get the diagnosis. For instance, in intraalveolar hemorrhage, alveolar proteinosis, Langerhans cell histiocytosis or lipid storage disorder. And sometimes it will suggest you some diagnoses that you will have to confirm with other examination. If the BAL show an alveolitis, you have to look for the cell type which is the more represented. If it's a lymphocytic alveolitis, you have to count the CD4 and CD8 lymphocytes and to perform the ratio, which will suggest you sarcoidosis if CD4 are over CD8, and which will suggest hypersensitivity pneumonitis on the other way. Sometimes the alveolitis is full of eosinophils, and so you will have to look for eosinophilic pneumonia or eosinophilic granulomatosis polyangiitis or drug-induced ILD. And sometimes it will be mixed between lymphocytes and neutrophils. And so most of the times it's what you see in connective tissue disorders or drug-induced disorders. And finally, when there is more neutrophils and if the chest CT scan imagings are compatible, it's what you see in fibrosis. Sometimes BAL will not help you and you have to discuss to perform the lung biopsy. But in children, the recommendations are very particular, and so it's less and less performed nowadays because it is an invasive procedure, and so you have to perform it only if treatment will be changed as a result, as I told you before. And sometimes there is a dilemma posed by patients that are very sick, which are on the verge of ventilation, and for which you need to have the more arguments you can to propose a specific treatment. And for those one, I think it's interesting to perform the biopsy. And so the American recommendations are quite close to the European one. And its lung biopsy should be performed if all other investigation did not give you the diagnosis. And video-assisted thoracoscopy should be preferred when it is possible. The principle of treatment, and then after we'll have some example. If possible, of course, the causative treatment is the best. But if there is no cause, there are some recommendations, European, American, and French for the treatment, which rely most of the time on systemic steroid first, then hydroxychloroquine and azithromycin. In some patients, and it should be an expert discussion, you can use other immunosuppressive drugs or more personalized biotherapies. The other supportive measures are very important, like respiratory support, nutritional support, vaccines, avoidance of tobacco smoke exposure, and in case of end-stage respiratory failure with lung fibrosis, lung transplantation can be proposed. So some example. First, Tessa, she is 5 months old. She presented with tachypnea, chest retraction, failure to thrive, and nocturnal hypoxia. Here is our chest CT scan. When you see especially ground glass opacity that are located in the perihilar regions. Here is our growth chart. BAL show macrophagic alveolitis, and she was first treated with steroid pulses with no improvement. So the next step was to perform a lung biopsy because she did not improve with treatment, and the biopsy allowed us to confirm the diagnosis of neuroendocrine cell hyperplasia of infancy, which was already suggested on the chest CT scan images. But the only way to confirm it is to perform the biopsy. NII belong to the persistent tachypnea of infancy entity, which is a specific entity that also includes pulmonary interstitial glycogenosis. The clinical presentation is not specific. The chest CT scan is very subjective but not specific either. And the positive diagnosis I had just told you before is histological with specific stainings for the two entities. Most of the time, the course will be spontaneously favorable and there is no response to systemic steroids. In pulmonary interstitial glycogenosis, the course is also most of the time favorable. Here are a typical chest CT scan of these two entities. So here the NEI with ground glass opacities that are located especially in perihilar regions, and here pulmonary interstitial glycogenosis. And in the picture which is below here, you see that it can resemble to a bronchopulmonary dysplasia with some case reports for which the differential diagnosis was not so easy. When you look at series that were published, there is a large series of 80 infants with a diagnostic of persistent tachypnea of infancy that underwent lung biopsy, and NEI was found in more than 60% of patients. More than half of the patients needed oxygen during their course, but almost half of the patients had a complete remission and almost all improved. Another smaller series of 9 cases of NEI. They were hypoxic in 30% of cases, but the complete recovery was observed in all patients. So the position of expert centers are different, but in our experience, we discuss lung biopsy case by case, and the biopsy can be interesting because in case where there is no response to steroids, the biopsy can help you to confirm the diagnostic of NEI, and then you will be able to reduce the anxiety in the family because you will be able to tell them that the disease will spontaneously resolve in the first 3 years of life, and it will also avoid you to increase the therapeutic pressure and to prescribe maybe more toxic drugs. Amel, she was 11 years old, born from related parents, originated from Algeria, and she was referred to Necker for chronic cough since the age of 4 years with dyspnea and exhaustion, and on the physical examination, she also had an homogeneous hepatosplenomegaly. Here is a chest CT scan with a reticulonodular pattern. Her lung function tests were normal, but she had elevated liver enzyme and lipid abnormalities with hypercholesterolemia and hypertriglyceridemia. She also had neutropenia and mild thrombopenia. The BAL show macrophagic alveolaritis with vacuolite macrophages. She had transbronchial biopsy at the same time of the bronchoscopy, and the results were subjective of a storage lipid disorder. Her sphingomyelinase dosage was very low, and molecular analysis led to the positive diagnosis of type B Niemann-Pick disease. So in front of an ILD associated to hepatosplenomegaly or lipid anomalies or cytopenies, neutropenia or thrombopenia, one should evoke storage disorder. The vacuolites and lipid-laden macrophage in the BAL fluid are very subjective of the diagnosis, and the enzymatic and molecular stories will confirm the diagnosis. Luana, she was 13 years old, born full term with no previous medical history. She was hospitalized for dyspnea that appeared 7 months before, and that worsened progressively. She had nocturnal hypoxia and a restrictive ventilatory defect on lung function test. Here is her chest CT scan, and the BAL display lymphocytic alveolitis with CD4 over CD8 ratio that was low, so there were more CD8 than CD4. And so when collecting the medical history, it was noted that she had a parotatom since 1 year with specific IgGs that were highly positive, and so the diagnosis of hypersensitivity pneumonitis, was confirmed, and she completely recovered after parrot eviction and a course of oral steroids. oops, to end, I know that the connective tissue disorder are specific online module, but I just want to focus on the new autoinflammatory disorder because it is very important to make positive diagnosis for those children because there is a specific treatment that is very efficient. So here is an example of SAVI, sting-associated vasculopathy with onset in infancy. Those children display cutaneous lesions with joint involvement and a very severe fibrotic interstitial lung disease. And they have a positive interferon signature with a constitutive overexpression of the interferon pathway, and they very well respond to ruxolitinib, which is a JAK inhibitor, JAK pathway inhibitor. So in conclusion, there are multiple causes of ILD in children. In many cases, you will not find any specific diagnosis, especially in infants. There are available European and American guidelines for the diagnostic assessment, management, monitoring, and treatment. And when there is a diagnosis of ILD with other organ involvement, the multidisciplinary collaboration is important for the diagnosis and the management of the children. And in the future, some new entities will be surely isolated, especially with the next generation sequencing technique that will allow to discover new disease and also new treatment. Thank you. 2 quick questions. Which of the following lesion is not usually present in the chest CT scan of a child with interstitial lung disease? Good. Ground glass opacity is a classical lesion of interstitial lung disease, even if it's usually related to alveolitis, but it belongs to the interstitial lung disease pattern. Cystic lesion can be seen when the ILD evolved toward fibrosis, so it's also a sign. Let's move to the next one. Okay. In bronchoalveolar lavage fluid, the presence of a lymphocytic alveolitis with an increased CD4 over CD8 ratio is suggestive of sarcoidosis, alveolar proteinosis, hypersensitivity pneumonitis, lung fibrosis. Good. So the hypersensitive pneumonitis is the other way around. The CD8 over CD4 ratio will be increased. And in alveolar proteinosis, there is no lymphocytic alveolitis. And I think it's okay.
Okay.
Thank you for your attention.
Thank you very much indeed, Alice. These were really very clear and very elegant presentations, 2 presentations on very complex issues, and you made it perfectly in time as well. So thank you very much. We've got time for a second round of discussion, and
okay.
There were quite a few questions on very different aspects, so you will have to do some work on the chat thereafter. And that I tried to group them. I will now not take the ones who are where the persons asked for very specific advice, providing more or less.
Okay, I look at the chat.
I took more the general ones.
Okay.
One of the ones was, what is your opinion on the role of azithromycin in treatment of ILDs?
In our center, we do not use it very often. We use it very often in airway disease, like bronchiolitis obliterans, or maybe sometimes in severe neutrophilic asthma, but we do not use it very often in ILD, even if it belongs to the French recommendations. It's not the case of all French centers, but we never had a real effect of that. On the other side, it's a well-tolerated treatment. So I think if you don't have any etiological diagnosis, and if the child have no effect of steroids or do not well tolerated steroid, then you can have a try. But I think if there is no effect after 3 or 4 months of treatment, you should stop.
Yeah, I agree.
In France, in Necker, we start with steroids, and usually if steroids are not sufficient, or if children are steroid dependent, then usually we proceed to other immunosuppressive drugs. Hydroxychloroquine is recommended, but is used in young children is not very easy because you have to control the electroretinogram, so it's not very easy. And we have good experiences with azathioprine and mycophenolate mofetil in some indications, but we always discuss in multidisciplinary meetings before decide those specific treatment.
Okay, thank you. So you're not of the opinion saying that either hydroxychloroquine or azithromycin should be the one of the two should be the second line therapy after steroids. So it's more on a individual basis, I understand. And
I have to say that even if it is the recommendations or experience, because I speak for my own, is that yes, it's not our first choice after steroids, indeed.
So we've now come to steroids, obviously in ILD. Are you using pulsed methylprednisolone very often, or do you reserve that for the more severe cases? Or do you
we use it very often when it is our first line treatment, because when you use it, when you do high dose pulse IV steroids, we do it 3 days once a month for 3 sessions, and then after we control the chest CT scan, the nocturnal oximetry, lung function test to decide if we go further. And I think that it's more well tolerated than prolonged oral steroids with less long-term toxicity regarding the eyes, the bones. And so we prefer start like that. But some children will partially respond to pulse, or will worsen their respiratory status, for example, just 1 or 2 weeks before the next pulse. And so sometimes we associate both pulse every month and oral steroids, but the minimal dosage, just to maintain the clinical remission.
Yeah. So in the dosage range of 10 to 30 milligram per kilogram, you start off at the very beginning with a high dose or a middle dose?
We start with 10 milligram per kilo for the infants, and once they are 20 kilos or more, we prescribe 300 milligram per square meter.
Mm-hmm. There was another question on steroids. Before lung biopsy. So do you try to avoid that at all?
No, because it's not an easy question, because it depends on what you evoke. For instance, if you have an infant with interstitial lung disease, which is not specific of nothing, or which can be compatible with surfactant disease, now it is recommended to perform genetic analysis before you perform the lung biopsy. And so the genetic analysis will take a long time. So you cannot wait for the results to start a treatment if the child is hypoxemic. So you will start on steroids anyway. And if the steroids failed, then there is no reason that you will mask any lesions of the lung biopsy that you might perform after, because it will mask some lesions if it works. If it's not working, there is no reason that the lung biopsy that you should perform after will not be relevant. But what we note in children, and especially in young children, is that most of the time, except for the knee, the lung biopsy will not give you the clue. I don't know if it's your experience, the other faculties, but
Yeah, I agree with that. And because we are running a bit late, I'd like to start off with the last to finish with the last question. You mentioned knee high. There were several questions on knee high, but one of those were, how long do the CT changes persist in patients with knee high?
Haha, it's a difficult question because we don't have longitudinal studies for those children. In our experience, in some children, even if the clinical recovery is complete, some add persistence ground glass in the chest CT scan, but usually it really improves with time. And for some, the CT scan will be normal after several years, but for some, they will have still some images. And this is the reason why we keep on follow those children with, for example, 1 year lung function test and 1 year clinical evaluation. And if the child is well with no symptoms and normal lung function test, then you don't have to control the chest CT scan every year or every 2 years, because it's not, there is the radiation, etc. So you have to keep on your clinical evaluation and lung function test evaluation, and to control the CT scan if you are worried in some way.
I'm aware of 1 or 2 papers with describing very small case series of family, actually, familial knee high, where they saw that even in young and also older adults, they still found these lesions. But this is again a special group here with familial knee high. Yeah. Okay, I think we have to break. Thank you very much again, Alice. You did a great job.
Thank you.
We'll come back at 1:20. Thank you.
Okay, and I will answer in the chat for the other question.
Okay, thank you very much.
Bye.
Bye-bye.